Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, everybody, and welcome back to another episode. Today, I have with us Dr. Melissa Vyvey, who is going to help us with the efficiency of doing that continuing medical education that is required of us when we're doctors and clinicians. I was just letting her know, we met at a conference this year, letting her know I was that doctor who, for a lot of years, would do her CME or CPD and continuing medical education throughout the year. But I was the one up till midnight, the night before it was due, hating on, why do I have to do this last minute every year, year after year? This was not fun, having to update the portal. I was always, why can't we have an app where we can just snap it while we're there and it uploads to the, this is what I wanted and desired. And anyway, so Melissa is here because she has very interesting things to say about CPD and CME and all the ways we can keep updated to date. So welcome. I'll let you introduce yourself.
Thanks so much, Sarah, and thanks so much for having me today. It's really exciting to be here. I'm Dr. Melissa Vyvey, and I'm a practicing family physician in Ottawa, Ontario. I work in the care of the elderly department at the Bruyère Hospital in geriatric rehab, which I love. And I am also the co-director of programs at the Foundation for Medical Practice Education, which is a not-for-profit medical education organization out of McMaster University that serves family doctors. We're one of the largest continuing medical education programs in the country for family doctors. We're by family doctors, for family doctors, and we're super passionate about providing family doctors with good quality, evidence-based continuing medical education that can also be fun and easy to organize and, be something positive in our clinical lives.
Yeah, yep. And you're also mumming today at home, I hear.
That's right. Yes, I'm also a wife and a mom of 2 kids, and my kids are home with me. So we'll see if they interrupt us at all.
No, I'm sure it will be fine. It's just to, I guess, put it in context that you're a practicing doctor, you're a mom, you're a wife, you're busy. And I think that in addition to that, you've taken on an educator role, helping other family doctors. So this is no easy feat, right? To do all of these hats. So tell us a little bit about how you structure your week or your month to be able to access and all of the things. Tell us more.
Sure. Yeah. So, I actually forgot one of my hats, which is I'm also an assistant professor at the University of Ottawa in the Department of Family Medicine. And that's an important one too, because I love teaching in all contexts. So how do I structure my time? Well, I do this very carefully. I work full time. I fortunately have a pretty flexible position in geriatric rehabilitation where I have busier days and I have less busy days.
Mhm.
And I am able to fit my medical education work in around that.
Mhm.
I also love having residents and medical students with me and do a lot of geriatric medicine teaching. Um, my husband's also a family doctor, and we're really lucky to have family support in Ottawa. My parents are here, my sisters are here, and I've got 2 great kids in a good community. So all those things have to really come together. And I'm sure, as you know, Sarah, it's just there's never a perfect balance. You're always adjusting things a little bit. My husband loves to say I'm obsessed with my schedule, which I really am. I'm always like, maybe if I just take 1 hour from here and put it here, then everything will be different.
Yeah.
Anyway, so I'm sure as many family doctors do, Um, I'm always thinking about how to be more efficient.
Mm.
There's so many demands on us these days.
Mm.
We're all working in a healthcare system that demands more and more of us. And we're doing this because we love it and we want to help patients. We want to be there for families. So we're always trying to make that time so that we
Mm.
can do those things.
Yeah.
And our continuing medical education is a really important part of that in helping us feel like we have self-efficacy as doctors, giving us confidence, helping us feel, aligned with our values, that we're doing our best. I think that matters
Mhm.
to us as physicians. Um, and then also we tend to be people who love to learn in medicine. It tends to attract people who are willing to go to school for an awful long time. So dare I say it, it can even be fun to continue learning. And it can be a big part of our social life as doctors too, a way that we connect with our
Mm.
colleagues.
Yeah, that's so true. What got you interested in this in the first place? Like where did this attraction come from? To be actually part of the leadership of it rather than just the participant in.
Yeah, so interestingly, it came from first being a participant. So I think I always loved teaching, all
Hmm.
through residency. I did a lot of teaching. When I first went out in practice, I formed a small group with a
Hmm.
bunch of my good friends from residency. And we've now been together for more than 10 years. We've met every month,
Hmm.
pretty much without fail. We've had babies, we've had difficult things happen to us, we've changed clinics, we've changed careers, we've had, successes, and we've had a lot of failures too that we've
Hmm.
chatted about together over the years. And it's been a hugely meaningful part of my life and of my career. And basically, I just loved my small group so much. And then at one point, they were looking for facilitator trainers. I'm the facilitator of my small group.
Hmm.
And I thought, well, I really love this program. So sure, I'll try being a facilitator trainer. And basically, it just worked my way up from there. I just kept saying, well, I'd love to write modules as well,
Hmm.
for this program. So I started writing modules and I just got more and more involved over the years until I got into a leadership position. So it was really from the passion of experiencing
Yeah.
this kind of learning firsthand.
Interesting. Okay, so it was a passion, interest, and it sounds like you had a really good support. Tell us about some of the possible things within your journey that you took to small group that really maybe helped you along in your family doctor career.
Well, it's hard to say. So many things, big and small, right? I think that my small group has meant so much to me. As an early career physician, it served that very important role of benchmarking. You
Hmm.
wonder, how am I doing? I have no idea. You have all this benchmarking when you're a resident. You have role models, and you're in this atmosphere where you're constantly able to compare your practice to other
Hmm.
people's practice.
Hmm.
And then you go out as a family physician. And even if you're in a very supportive clinic, for the most part, it's you and the patient with
Yeah.
the door closed.
Yeah. Yeah.
And you start to wonder, am I doing this right? And
Yeah.
so I think in the early years of my small group, it was a huge comfort to me. Of course, I wasn't always doing it right, but neither was anyone else in my group.
Yeah.
And these were my friends, the people that I respected and cared about, the most in clinical medicine. So to know that they were doing about the same as I was, and
Yeah.
that when I made a mistake, they had my back. We could
Hmm.
debrief about it.
Yeah.
They could give me some feedback, and I could improve. That really gave me so much confidence as an early career clinician. And then
Yeah.
I think that has continued. I mean, really, that never goes away.
Yeah.
Um, but it has developed into even more than that. In my small group, one of my good friends in my small group did care of the elderly, and I was
Yeah.
not initially in care of the elderly. I was initially a full practice family doc at a community health center, which I loved. But I also over the years kept thinking, you have such a cool job. Like I kept, when she talked about her job, I'd be like, that job sounds so fun, you know?
Mhm.
And then, and then one day I realized I could maybe actually do that job. And I went back and I did some extra training in care of the elderly. And now I work with her, um, with my friend who's in my small group. So that's just been like a huge joy
Yeah.
in my life and a way that I've been able to grow in my career and learn and change in a really positive way. Um,
Yeah.
so I could really go on, but
Yeah.
many things have been great about my small group.
Yeah, no, I hear how valuable that is. And of course, we know that connection can be a really good force for good against things like burnout and career, um, I don't know, regret even, that we see sometimes with physicians and clinicians wondering, why did I get into this? Is this what I signed up for? This is hard. I don't like it. But when you've got that sounding board, it sounds like it can be a real source of validation, like you said, and that comfort of there's others with me. Yeah, really sounds very, very delightful, like something we should be pursuing. Is that something that you have talked to registrars about, forming small groups with others and peers, or has that been part of your education piece?
Yeah, so we, at the foundation, we do have a residency program as well.
Mhm.
And we're in all of the residency programs in Canada, except for one. Um, and we encourage residents to form small groups.
Mhm.
And we basically, our program is that we have small groups facilitated by a trained facilitator,
Yeah.
learning around a module which we produce, which has cases and all of the up to date evidence around a certain topic in family medicine. So we basically have the same program that we have for practicing physicians, and we provide it to residents with some modifications
Mhm.
to meet them where they're at.
Yeah.
So,
Yeah.
yes, definitely.
And so those small groups are then encouraged to stay together and keep doing different modules together, but also make this more than just learning.
That's right. Yes.
Haha. Sneaky and good in a good way.
Well, yeah, I mean, I think the really sneaky part of it is that, what's wonderful about learning in a small group is that it's also a very evidence-based way to learn, in the
Mm.
sense that we know from the medical education literature that people who learn in small groups make practice change
Mhm.
much more often than people who learn on their own. So there's some kind of cognitive magic that happens in a small group. I think it is that back and forth, the ability to receive feedback, to consolidate knowledge together, to sort of scaffold your thinking, your knowledge, your
Mhm.
ideas with others, to have some kind of repository of knowledge that you all share over the years that you can refer back to. Remember that time? In my group, it's always remember the fatty liver module. Like we just keep having to return to certain modules,
Yeah.
and what
Yeah.
we learned there. And so there's something about that that really is a more effective way to learn in terms of not just like actually acquisition of knowledge, but the evidence shows in terms of actually creating change in your
Mm.
practice. So that downstream effect that we really want to be having for our patients.
Yeah, yeah, agree. I think even storytelling, like when we bring together cases of things we've seen, that can consolidate knowledge because it puts it into a out of the textbook and into a real life model, which helps our human brain remember that we can, like you said, scaffold against storytelling and in hearing other people's opinion, what's been possible for them, how they've addressed that with different types of patients. That really brings that education into a easy, practical approach. Yeah.
Yeah, absolutely. I think it's really important for us as physicians to understand how we learn.
Mm.
And a big way that we learn is that we have um, these cases in our minds. So we have like prototypical cases, you
Mm-hmm.
know, the person who takes a long plane flight and then has all the typical signs of a DVT. We have exemplars, which are like our own cases that we've seen in our own practice, where something might be just a little off or a little different, but we remember that. So the different
Mm-hmm.
times maybe we've seen DVT that it surprised us. And then we have our full illness scripts. So that's like the entirety of what we know about that topic. And, you know, I think it's really important for us to understand that we have these things in our minds and they'll often come to us automatically.
Mm-hmm.
Um, and we use that, and that's fine. That's all good. That's part of what we do in medicine, especially it's such a fast-paced environment. Using some of those automatic thoughts is fine. But what we need from our medical education is to also teach us how to slow down and
Mm-hmm.
deliberately think through a case. So take that
Mm-hmm.
illness script and say, okay, we think it's a DVT, but how might it be different? What else might it be? What is the differential diagnosis? What is not fitting here? What is fitting? And that kind of thing. So any kind of medical education that helps us do that and practice that skill is what is going to help us provide the best care and prevent error.
Yeah, yeah. Demonstrating things like bias or even that uncertainty of clinical practice, because not everything that we get in that room is easy and straightforward. And I remember a module I did where it was good because it was if it doesn't fit, it probably isn't one of the common things. And that's what you need to know about rare disease. It's not necessarily the rare disease is, but this is not fitting a usual pattern. Because I know a lot of physicians will be self-critical of themselves for not being able to figure it out. And some things are truly very difficult to figure out. Even internal medicine specialists will get the undifferentiated patient that is very hard workup to figure out.
Yes, yes.
Yeah.
Yeah, and
Um,
the other side of that is that sometimes there is no right answer, right?
yeah.
So the other side is sometimes it seems hard to figure out, but in family medicine, we're often seeing these very undifferentiated complaints. Lots of
Mhm.
specialties see undifferentiated complaints. And, you know, there's this propagation of clinical practice guidelines that are just getting longer, more complicated all the time, more numerous, and more difficult to keep up with. And, you know, we try to apply those, but really in the end, you know, our patients don't always fit into those boxes.
Mhm.
And I think that's another helpful thing that sometimes continuing medical education can do. Sometimes there really is a right answer, and it's teaching us how to find it. And sometimes it's just having the confidence to say, there's no right answer, but I'm going to try something. and and then I'm going to know how to evaluate it, right?
Yeah.
And
Yeah.
I'm going to readjust as needed.
Yeah.
And that is true clinical acumen to be able
Mhm.
to do that. Yeah.
Yeah, yeah. So tell us about the origin of these modules and this program with physicians and family physicians and how the system works.
Sure. So we started about 30 years ago at McMaster University, and we really grew out of medical education research and principles. So the fact, just as you were saying, like stories, case-based learning, we know that this helps clinicians. McMaster was really in its problem-based learning model at the forefront of this type of medical education. Um, yeah, so we started out with these modules, but then we have developed a whole program kind of around the modules, which includes, you know, how small groups are best function, which
Hmm.
really involves having a good facilitator. We train our facilitators and we update that training regularly so that facilitators can really help to guide conversation in small groups. Um, Good facilitation is so key in whatever continuing medical education you're looking at. I think it can really help to foster that climate of supportive learning. It can
Hmm.
help people to go to the depth they need to go to, right? Keep asking the questions. But what if this? But what if that? And that kind of thing. And it really promotes reflection. And then we also have reflection tools that our groups do together. They do one right after completing a discussion of a module. And we also know from the literature that structured reflection, sitting down, really thinking about what is it that I'm going to change here. So I just learned a bunch of stuff, but what are my pearls? What are my take home? We call them commitments to change. What am I going to commit to here and now, and how will I do it? And actually reflecting as a group, what will enable me to make that change? And what are some barriers that I might face that I could actually think about now and try to prevent? And then we have a follow-up reflection tool, which you do 1 to 3 months after doing the module with your group. You return to it. And we know that repetition, I think this is obvious, but repetition is so good for us. I think that's one problem I often have with conferences. I learn so much, but then it's there once, and then I go and I don't know, a few months later, it's gone. But this is one way that we bring it back. So we have a structured reflection tool. We come back and say, look at the initial reflection tool and say, this is what we thought we would change. So what happened? Did the change happen? If not, why not?
Yeah.
And we also have a practice improvement activity, which is a structured quality improvement project. So as I'm sure you know, it's so ubiquitous now that quality improvement is such a great way to learn and to make practice change. So for a certain practice change to take it even further, more in depth, measure things, come up with a real strategy, do those plan, do, study, act cycles that we know about in quality improvement. We have a specific activity for that. Those are the those are the elements of the program.
And you said the facilitators are all family physicians, I presume, practicing. Did they also self-identify, having come through as participants, saying, hey, this was fun, I want to be a facilitator? Or are they working in universities? What are you kind of seeing as facilitator people?
Yeah, so our facilitators are peer facilitators. So they are members of the program. We really stress that they're co-learners. We have more than 6,000 family physicians in our program. So we have more than 800 facilitators. And those facilitators are just anyone in the group who wants to volunteer to facilitate. And sometimes they pass the torch during the time of, their group. They take turns or that kind of thing, or co-facilitate. We allow that as well.
Yeah. What does facilitated training take? So how long would that take? What is the process of becoming a facilitator?
We have some facilitator training videos for the kind of didactic portion. And we're very, again, geeks about being evidence-based. So we do a kind of flipped classroom approach, which is where, you learn the stuff at home through the videos. So there's a facilitator guide. And then the facilitator training workshop is 2 hours on Zoom. And you actually get to practice being a facilitator in a small group with a facilitator trainer who gives feedback.
Wow. Very cool. So it's kind of a full circle moment at that point.
Yes. Yes.
Love it. And are the family doctors who are involved, is it like a subscription model? Is it they volunteer facilitators? How does that work?
Yeah, so for our program, it's a longitudinal program. So people sign up for a year at a time. Many of our groups have been together for as long as my group has. Groups tend to stay together. We have some groups that have been around for 30 years. So those are people who sign up, routinely every year. And our facilitators don't pay any fee. So they just provide their skills for facilitation. They do have to fill out the attendance record and submit it so that people can, in their group, can obtain their Main Pro Plus credits. And they schedule meetings and that kind of thing. So to acknowledge their hard work of keeping the group going, they don't pay the membership fee.
Got it. Okay. That's a nice incentive for facilitators. I know that everybody, like all physicians, all clinicians, have to do continuing medical education and usually submit some record of that to their place of getting credits for that work. Has that been considered within this framework? Is that easier done for you? Like, how does it work from collecting those main points in Canada specifically, I guess?
Yeah, so we actually have a relationship with the College of Family Physicians. So we upload credits directly. So you don't have to submit them yourself. You give us your CFPC number and we do that for you.
Okay, so your attendance sheet equals points.
That's right. Yeah. And
Oh,
most family physicians in our program get all the points they need each year
yeah.
from our program because
Yeah,
we're
yeah.
certified for a lot of credits. So
That's right, because it's got that self-reflection piece, the action plan, the taking action, the coming back and reviewing it, the facilitated and peer discussion process that gives it that solid, evidence-based, good quality practice change education, which is what all the colleges are looking for, and even fulfilling some of that mandatory physician practice improvement piece by the sounds of it as well, which is wonderful. Yeah. Anything else about continuing medical education that you've learned along the way that could be helpful to others listening?
Yeah, absolutely. I think, we have a kind of formula based on the literature at the foundation in our practice-based learning programs. But these are pearls that you can use in any type of medical education. So if you're going to a conference at your local hospital, or if you're attending a lunch and learn, you can use the same principles. Um, and so I can go through them if you would like.
Absolutely.
Okay.
Please do.
Yeah.
Yeah.
So I think the first one is to really make sure that you understand what your learning gaps are before you
Mhm.
start.
Yeah.
So what we know from the literature, and this is probably not surprising, is that we tend to like to learn something we're actually already pretty comfortable with.
Yeah.
We don't tend to go for the things that are really hard.
Yeah.
And so sometimes we need to be conscious of that and to
Mhm.
really think about whether we want to choose something that's a bit harder for us. And how do we even know? Of course, there's our subjective learning needs. We
Mhm.
know we have a learning need. Maybe we've seen a case recently that was really hard for us. We find that we're referring constantly for a problem that we'd like to be able to manage better ourselves. But then there's also the objective learning needs or the unperceived needs. And this is the
Mhm.
hardest part. So this is what we don't know, we don't know.
Yeah.
And so, how do you find out what you don't know, you don't know? And the best way to do that is to really expose yourself to your colleagues. So, what are they doing? What are, what? So, it's those conversations. They can happen in the lunchroom, where someone says, "Oh, I tried, giving that new kind of analgesia before putting in an IUD today." And you think,
Mm.
"What? What is this?"
What? Yeah.
Right? So it's paying attention to those moments where you're
Mm.
alerted to something that you haven't heard about. And then I've started, whenever I go to a conference, I'll really look at the agenda beforehand and think about which talks to go to, because
Mhm.
we all know about cognitive overload theory. It's a real thing.
Yeah.
We've all probably experienced it at conferences. It's not always best to go to everything, right? So if you can, really think about what you're trying to learn and go to those topics preferentially.
Mhm.
And obviously, I'm going to argue that if there's a more interactive session where you
Yeah.
have some kind of small group, or some kind of benchmarking with your colleagues, discussion, that's going to be a richer experience than a very didactic experience. So
Yeah.
that's another way to pick things. And then I really encourage taking some time, and maybe you only go to every other talk. Maybe you
Mm.
go to one talk for an hour and then you take a full hour to actually sit down and reflect. What
Mhm.
are your pearls? What did you learn? And are there a couple of changes that you want to take away? Again, we have to think from a quality improvement perspective, always
Mhm.
thinking small changes at first, and then we build on them, right? And take some time to really sit down, commit to a change, and reflect on how you're going to do it. What are the steps? Do you need to put a stamp into your EMR? How are you going to write the stamp? Do you want to write it right now? Do you want to run it by someone? Maybe you need to talk to your colleagues about putting that stamp in your EMR.
Mm.
Um, they might want to use it too. What kind of barriers are you going to remember to use the stamp? How might you remind yourself? What kind of enablers, like is there someone at your clinic who's really good with tech who might be able to help you make that stamp really snazzy and easy to use in your electronic medical record? So actually taking time to do that. And then I would encourage you to set yourself some kind of reminder in the future to come back to this. So you've written this down somewhere. Maybe you have, I don't know, a special note-taking program on your computer or your phone, or maybe an old-fashioned notebook. And then you put in your calendar at some point in the future to really come back and think about, did I make that change and how did it go? And then that brings in that QI element, that quality improvement element of maybe trying to measure if you made the change. Like you might want to actually look, out of the last 5 people I've seen with that problem, did I use that stamp in my electronic medical record? Um, and if I only used it for 2, well, why? And,
Mhm.
What could I change? What might I do next?
Yeah, yeah. I can see that if we got you to set up conferences, things would be different. And
That's probably
probably
true.
really helpful to be able to consolidate learning and to be able to change this into a really practical form. But they were really good outlines, I guess, for how to approach anything that you're offered in terms of that medical education, whether it be conferences, lunch and learns, like you said. It's a good framework for how do I use this content? How do I use this information in a way that's really effective for me? And even how to identify things that I don't know that I don't know. I think
Yes.
that we all do that. We walk past something and we're like, what's that? We see something, what's that for? Or what did you use? Tell me again about that. Yeah. So we want to be at the top of our game in terms of care for patients and quality and improving patient outcomes with really good levels of education. And then we are constantly needing to add information. It can feel overwhelming, but I think that the structure you gave us really cements that nicely, which is helpful. Thank you.
You're welcome. I want
Yeah.
to say too that I think one thing that we sometimes don't think about is that it's sometimes just as important to de-implement things. We often are always adding,
Yes,
but
yes,
remember
yes.
you can also take away.
Yeah.
Sometimes
Oh,
that can make your clinical day easier.
yes.
Although as a change in your practice, the literature shows it's harder to de-implement things.
Mm-hmm. Mm-hmm.
But then once you've de-implemented it, something that
Yes.
you were doing that you didn't need to do, that maybe
Yes.
wasn't evidence-based, wasn't a quality practice,
Yeah.
you're taking one extra thing out of your day that you don't
Wonderful.
need to do anymore. And that helps with your efficiency and
Mm-hmm.
making your
Have you got an
clinical day a bit
example of
better.
that for us? What you might have done, just 1 or 2 examples of what you've done in your clinical practice based on some of this learning that has been lesser.
Yeah, a lesser. Well, I think that probably the biggest one, well, basically anything by the Choosing Wisely campaign, you know, in Canada.
True that, true that.
I love the Choosing Wisely website. That's actually a great website for looking for practice changes and
Mhm.
quick updates on things. But there's lots there about you know the fact that it's not really helpful to screen for certain conditions, right?
Mhm.
So not taking time to do that, or the fact that doing a physical exam every year on every patient is not helpful.
Mhm.
In the area of geriatrics, for example, reducing polypharmacy,
Mhm.
reducing the number of medications someone is on, is so satisfying because
Mhm.
it simplifies things and it's so good for the patient. It
Mm.
really, reduces their risk of adverse events, reduces their risk of drug interactions, and it makes your list shorter, less prescription renewals. The patient
Yeah.
is healthier. It's a win-win
Yeah.
situation, but it is some work, of course. I think if anyone who's tackled polypharmacy in a patient, I
Mhm.
told you you needed this medication 5 years ago, and now I'm backtracking. Sometimes
Yeah.
one of the barriers can be, patient expectation, communication being difficult, that kind of thing.
Yeah.
So yeah, it is some work, but it can be very good work.
Yeah, I love that. So it's not just about doing more. I like that message too. That's a good message.
Yeah.
Anything we didn't talk about that you wanted to talk about today?
I think we've talked about most things. I guess the only other thing I would say is that, I think that trying to find some fun in it is really important.
Mm.
As much as it's important to learn and look at your learning gaps, I think that the way that you learn. So some of our small groups, learn from a cottage, from a
Mhm.
hot tub, from their favorite restaurant in
Mm.
town, and I really think that that aspect of physician wellness is so important, that our continuing medical education, our jobs are busy and they're heavy sometimes, but learning together can be fun, and it should
Mm.
be fun.
Love that. Love that. Okay,
Yeah.
perfect. Where do people find out more? So what would be the best place for them to find out more about your program or the program that is available for family doctors?
So we have a website. It's fmpe.org. So the Foundation for Medical Practice Education, or acronym fmpe.org, and everything is on there. We also have social media on Facebook and LinkedIn. Um, so yeah, those would probably be the best places. Also, your local university, like we're involved in most family medicine programs.
Yeah. Do you find that the College of Family Physicians in each province is also helping physicians find you?
Sometimes, yeah, it depends on the province.
Hmm.
And yeah, that is definitely one issue we've always had, which is just how do groups come together? And some of our groups are made up of colleagues all in the same
Hmm.
clinic. Some are, friends. Now, actually, before the pandemic, almost all of our groups met in person.
Hmm.
And these days, it's about 50-50 in terms of meeting in person and virtually. And the virtual aspect has really opened things up because now, if there are some remote physicians, living up north in Canada, maybe they have a similar practice, even though they don't live anywhere close to each other, and they can actually benefit from learning together
Yeah.
over Zoom or a comparable
Yeah.
platform.
Does the organization help facilitate those small groups? Like, do you go on there and say, here's what sort of practice I'm in, and you get buddied up with others?
We do try to match up people into small groups as much as we can.
Hmm.
Um, but for the most part, people find their own small groups because it is so based on, their own connections and
Hmm.
and that kind of thing. Yeah.
Yeah, love it. Well, thank you so very much for this conversation. I think that we've learned some pearls about how to make continuing medical education more useful, easier to grasp, and even a model or framework for how to use other information coming in from things like conferences and that. So really thankful for this conversation.
Thank you, Sarah. It's really been my pleasure. Thanks for having
Yeah,
me.
have a great week, everybody, and we'll see you
Yes.
next time. Bye.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done. with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.